profiles for the newer drugs, and there's fewer drug-drug interactions. In terms of efficacy, they're about the same in terms of how much they lower the future possibilities of seizures, right? So what is epilepsy?
Convulsions, just hyperactive nervous activity.
Hyperactive nervous activity in the central nervous system.
Like constant firing.
Constant firing of neurons, yeah, that produce basically a seizure. Has anybody ever witnessed a seizure?
Yeah.
Yeah, oh wow, well, a few of you. Like just in your personal life or in the ER where you were working, in personal life? Wow, they can be really scary, right? Yeah. Has anybody seen anybody in status epilepticus? You have. What did you see?
It was just like micro, like it was weird. It was like he wasn't stopping.
Yeah, exactly. It's a seizure that won't stop. But, yeah, and it is.
It's an emergency.
Yeah, you can die.
But there's a medicine that you have to like insert.
Rectally?
Yeah, rectally.
Yes. So it's a benzodiazepine that you insert rectally, diazepam. That can be inserted rectally, and that is something that patients who have epilepsy are prescribed as a precaution. Their families are aware of it, and it can be used if they need to use it. But basically, so let's see if this is, the next slide. So seizures are abnormal synchronization and excessive excitation of cortical neurons. So cortical neurons are neurons that are in your cortex. Where's your cortex? In the front of your brain, right? So the cortex is this part. You can have. I'm not going to get into too much the definition of seizures. Have you guys had neurology or no? No. Is that next semester? Okay. So I would think just broadly there are focal or partial seizures and then generalized seizures. And then what do you think differentiates the two?
One part of the brain.
Exactly.
And then generalized all over.
Yes. So focal or partial tends to be one area of the brain, and then generalized means it starts in one area but it spreads throughout the entire brain. You have to have this kind of movement with seizures. No. In children, has anybody heard of absence seizures?
Oh, yes.
Yeah, absence seizures. Yes. How would you characterize absence seizures? Okay.
Well, they don't have. You usually see them in kids, like the child can be in class and just staring.
Yes. They'll just space out for a few seconds, and you can have hundreds and hundreds of them every day. How do you think a child like that would present?
Forced people.
Like a zombie, just not.
Well, they're normal between what we perceive as normal, I guess you could say. And these last for maybe a second, milliseconds, few seconds. What's that?
They don't remember.
Yeah. Yeah, so they won't know that it's happening. While they're doing it, they could look like they're just staring off into space, so you think they're daydreaming. But a lot of these kids will have developmental delay. And it isn't until that their seizures are under control that you see them kind of catch up. It also happens a lot with kids who are on the spectrum, unfortunately. So kids who have been diagnosed with autism can have a co-diagnosis of seizures, and it tends to be absence seizures. And absence seizures can be really tricky to diagnose. So neurologists will basically use EEGs to diagnose these in children. If any of you have kids, imagine getting it. They have to be hospitalized and sedated and all this stuff. So it can be really difficult. So epilepsy basically means you have recurrent, unprovoked seizures. So what can provoke a seizure?
Fever.
Okay, yeah, fever. Yeah. What's that?
Being startled.
Being startled?
Like,
what do you mean?
Yeah, I guess like being scared.
Being scared?
Like if something happens, like
it has to be very extreme, like a trauma, probably. I'm really sorry. So some people think that those who have, for some reason, a lower seizure threshold, so something like strobe lights may set off or may trigger a seizure, right? But extreme trauma to the brain, that can cause seizures. Illnesses can cause seizures, so febrile illness in young children. So epilepsy means that there isn't any of those things. These are what we think of as unprovoked seizures. So we can't find a cause for those seizures. And that means that a person gets diagnosed with epilepsy. So those are the definitions that I want you guys to be aware of for the lecture. Don't focus too much on the different types of seizures. In some of my slides, I said, oh, they're used for partial seizures or generalized seizures. I don't really care if you guys know that right now. I think you'll learn more in neurology. You'll learn about really the heavy-duty antiepileptics and when they're used. So what's considered first line. I'm not going to get into that too much because it's a lot of clinical. And I want us to get a really good understanding of the pharmacokinetics and dynamics and the stuff that I really wrote up on the board. That's what you should focus on. So, okay, so we said AEDs, what they are. The goal, obviously, with AEDs is that you decrease the frequency and or severity of seizures in people with epilepsy. You treat the symptom of seizures. We have no cure for epilepsy, unfortunately. And then the goal is that you maximize quality of life, right, by minimizing seizures and adverse drug effects. If a patient is diagnosed with epilepsy, and they are seizure-free for 2 years, sometimes they can be considered to stop the seizure medication. I had a fellow resident when I was in residency who was diagnosed with epilepsy. I don't know why until this day, but she had a really hard time because she needed to drive all over the place for her clinical rotations. And when you're diagnosed with epilepsy, your license is taken away from you until your clinician, whoever is taking care of it, can sign off on saying, yeah, this person now is controlled, their seizures are controlled, and they can go back to driving. So it like threw our whole program off and everything, but I mean, you do what you need to do. Okay. I put this slide in there so that for those of you who love Armando, this is Armando's talk about mechanisms of action. And it's a great way to remember it. If we have time, I'll try to add a few things to this. But again, it's in there for those who want that visual. Okay. So this is a very long list of antiepileptics. The ones that are bolded are the ones that I'm going to go through that I want you to be aware of for the exam, okay? But be aware of the names of these drugs so that when they come up, you will recognize that they are an antiepileptic, okay?
Oh, sorry, so we should be aware of the name in both, so basically know everything.
Know the names, not for the exam, just so you know that when somebody mentions lacosamide, right, that is an antiepileptic drug. Yeah, but I'm not going to test you on that fact in the exam. No. So the bolded is what you will be tested on. Okay. Okay. So, let me mention one thing here. So these drugs here are divided by their mechanism of action. Yes.
Are you gonna put
their brand name?
their brand name?
So I never use brand names, but if you guys want me to, I will. You know some of these based on the brand name. So I'll include it for the exam, but I don't have time to update the lecture slides. I apologize. But if you guys want, I feel like brand name is something you will, if you're not familiar with it now, you will get it in your clinical rotation because whoever you're with, they will just throw out the brand name with the generic or with the drug name. And so you'll pick up on it. But I think it's really good to have a clear understanding of the drug name. Because a lot of these drugs are generic. Okay. If you want both on the exam, I'll include both. I have no problem with that. So basically this slide is divided into the mechanisms of action, which I think is a really nice way to remember antiepileptics as grouping them in terms of their mechanisms of action, their side effect profile, as well as their effects on enzymes that are involved in metabolism in the body. Okay, so let's get started. Okay, so drugs that affect the voltage-dependent sodium channels, right? So I don't have a picture of this, but if you remember back to neuro, right, what is basically causing the action potential to go down.
Sodium?
Yes. What's sodium going in or out?
In.
In. Yeah, exactly. And when it gets to the end, and it's the action potential is right at the synapse, what other channels do you have that are going to cause, exactly, good, and calcium is going in or out?
In.
It goes in as well. So what do you think these drugs are going to do to the sodium channel?
Blocks it.
Exactly, they're going to be basically preventing that influx of sodium into the cell. Okay, so binds to voltage-dependent sodium channels. We think after they've changed from activated to inactivated state, and essentially its effect increases with the rate of neuronal firing. So as a neuron is firing more and more, this drug is going to be more effective. That's why we think that it's forget what I'm just saying right now. Yeah, so as a neuron is firing more and more, this drug will have a greater effect in inhibiting the influx of sodium into the neuron. So it makes it for a very effective anti-epileptic medication. In terms of its pharmacokinetics, it's highly protein bound, and it is metabolized by the cytochrome P450 system. It has a main metabolite that is an active metabolite. So you can measure this active metabolite in the serum, and it is also a broad inducer of the cytochrome P450 system, okay? As well as UGT glucuronidation. So did you guys cover the different kinds of metabolism, drug metabolism before? So cytochrome P450, UGT, glucuronidation. Okay, those are not unfamiliar terms, hopefully. Okay.
Just went over cytochrome.
Yeah, we did
Yeah,
cytochrome P450.
cytochrome more than the others.
Okay, basically, just very, very generic way to remember is that these are all classes of enzymes that help metabolize chemicals in the liver, basically. So whether it's a drug or something else that's physiologic. And the reason why they have such a huge role in antiepileptics is because antiepileptics have such a huge effect on other drugs and the metabolism of other drugs because they do this. They either induce or inhibit these enzymes. So cytochrome P450 enzymes or glucuronidation enzymes. You're going to find this in every single slide in this lecture, and that's why I really wanted you guys to do that bottom box. But I'll try to maybe go through it a little bit with you after. But you have to be aware of what highly induces the cytochrome P450 enzymes, what doesn't. Because when you prescribe anti-epileptics, you're probably going to be prescribing other drugs with them for these patients, and you just have to be aware. Thankfully, in this day and age, we have computers to do a lot of this stuff for us, where you have you can just input the names of the drugs, and a red flag warning will pop up on the screen saying, "Hey, do you really want to prescribe this drug? It affects the metabolism of this other drug." And then that'll remind you to kind of look that up and review that concept. But just have a good understanding of that. I remember what I wanted to say here. So there's something called autoinduction. Has anybody ever come across this term? No? Okay. So carbamazepine induces its own metabolism because not only is it metabolized by this particular cytochrome P450 enzyme, but it also induces it to work. Does that make sense?
Yeah.
So it has this concept of autoinduction built into its metabolism. So not only will it metabolize its own self, but it will also metabolize other drugs. So that's one thing that you want to be aware of with carbamazepine in terms of its pharmacokinetics. How do you think that would play out clinically?
So because it's an inducer, it will make the metabolism go on faster and then the levels of the drug.
Exactly. Yeah. So what do you have to do? with more? Yeah, but how do you know how to increase the dose in the patient? What are you going to be doing to kind of help you figure that out? Exactly, yeah. So this is a drug that you want to definitely get serum checks on because of this principle. Okay. So I put in this slide how it's usually done, the serum checks for carbamazepine, just for your knowledge. But the main point that I want to get across is that it needs to be frequent enough because of this autoinduction concept. So not only can carbamazepine influence the metabolism of other drugs can influence its metabolism too, right? Because there are other drugs that will induce cytochrome P450 system. And the other thing to remember is that sometimes patients are on 2 anti-epileptic drugs, so then it can get really confusing, right? So again, just being aware of these concepts will help you when you're in practice to look them up and make sure that what you're prescribing to a patient is not going to be detrimental to them. So in terms of drug-drug interactions, I listed just a few, so carbamazepine is one that can really reduce the effectiveness of hormonal contraception. Some drugs can inhibit the clearance of carbamazepine, so that would lead to, if you're inhibiting a clearance of a drug, what's going to happen to that drug level in the body? It's going to increase, right? And then other drugs will do the opposite by inducing the enzymes that metabolize it and decrease its level. So do these concepts make sense? Okay. The contraindications for carbamazepine is a history of liver disease, AV heart block, or using an MAOI, which hopefully you remember what that is from psych. In terms of its side effects, so its side effects are many. So remember, this is going to be an old or a new drug? Old. It's going to be old, exactly. So the most common side effects with a lot of the antiepileptics, not just carbamazepine, you have GI upset. You can lower the sodium levels, which we'll talk about briefly later on. Rash. Rash is something that we worry about a lot in antiepileptics. Why is that?
Because it was folate?
No. What's the worst rash? It could be Stevens-Johnson syndrome. Yeah, which is a life-threatening rash that patients can get and requires critical care, ICU care for patients. So we'll talk about what Stevens-Johnson syndrome is. They can get pruritus, which is itching, or fluid retention, which has a role with the hyponatremia. In men, they can have sexual dysfunction and low testosterone levels. This is usually reversible when you stop the drug. There's neurotoxic side effects, so drowsiness, dizziness, changes in vision, feeling tired, headaches. Life-threatening, we mentioned Stevens-Johnson syndrome and toxic epidermal necrolysis. And then bone marrow suppression. So not just thrombocytopenia, which is low platelet count or reduced platelet count, aplastic anemia, and leukopenia. These can be transient, but patients on carbamazepine usually are monitored with what? CBCs. Yeah. So yes, and their drug levels are monitored with the serum levels. Yeah. Okay. So let's talk about Stevens-Johnson syndrome and toxic epidermal necrolysis. So what do these pictures look like? Yes.
I think there was on the news, there was a girl that developed that symptom. And it was,
Stevens-Johnson syndrome?
Yeah.
Yeah.
It's so bad.
Yeah. What does that look like to you? It looks like a burn. It looks like a burn, and that's how it's treated. So like a burn ICU patient. So these patients can have very severe mucocutaneous reactions. So not only does it affect the skin, it also affects the mucous membranes. Exactly. You have extensive necrosis and detachment of the epidermis. So it's like they're sloughing off. You can see it in this top picture right here, right where the skin is sloughing off, basically. Mucous membranes affect the majority of these patients. It can be ocular, oral, or genital. And then Stevens-Johnson's and toxic epidermal necrolysis are considered to be a continuum of the same disease process. So Stevens-Johnson's is where you have less than 10% of the body being involved, And then toxic epidermal necrolysis is where you have more than 30%. And in that intermediate area, the gray zone, you watch those patients and to see which way they're gonna go. Yeah.
That's only from taking hypertension.
Yes, it can be just from taking specific kinds of drugs, yes.
Oh, specific type.
Yeah, antiepileptics tend to be the big
Oh,
ones
the
that we
other
think
drugs
of with
too.
Stevens Johnson. Yeah,
Oh.
yeah. So this is generally considered a drug reaction.
Alright.
So the patients are treated like as if they've had burns. So they need a lot of just fluid electrolyte support. They're usually in critical care, ICU, especially if they have huge areas of the body involved. So they're gonna have humongous fluid losses. They can go into shock, and so they're gonna be in the hospital.
So does it like?
Will it resolve?
It's just like a burn?
Yeah. Oh yeah, this is painful. Yeah. Yeah, if you've ever had like a blister, you know, from just burning yourself and then the skin, imagine that on this much body surface. Yeah, very painful. So the point of this slide, not to get lost in the details, but we think that certain HLA subtypes may have a greater risk of developing Stevens-Johnson syndrome when given an antiepileptic drug such as carbamazepine, right? So sometimes patients will be screened for certain HLA alleles to see if they have that higher risk of developing Stevens-Johnson syndrome. There are some studies where they found that all the cases of Stevens-Johnson syndrome patients had these types of HLA alleles. And so some neurologists, I haven't seen this in practice, but some neurologists now may be screening their patients before they start them on some of these drugs that have a higher risk of this. So just being aware of this fact is good. Okay. So let's talk about lamotrigine. It's in this group in terms of mechanisms of action, but its mechanism of action is not 100% understood. So we think that it's blocking repetitive firing of neurons by basically inactivating these sodium channels. It also may influence the synthesis of glutamate and aspartate, since these diminish the release of excitatory neurotransmitters. I listed the indications. Again, it's just there. One thing to note with lamotrigine is it's also used in bipolar disorder. So remember back to our psych lecture when I said we'll talk about antiepileptics, but antiepileptics are used for bipolar disorder. So this is one that can be used for bipolar disorder. And then in terms of formulation, so there's an IR formulation and an ER formulation. What's IR stand for? Immediate release. And then ER? Extended release. So IR is given BID, right, twice a day, and ER is given once a day, right? And obviously once a day is going to be much easier to take than twice a day. So just so you're familiar with that terminology. Okay, so again, it's about half bound to protein. It's metabolized by UGT, glucouronidation, and other non-cytochrome transformations to inactive metabolites that are excreted in the urine. Again, there's drug-drug interactions that I've listed there. So drugs that inhibit glucouronidation are going to do what to the drug levels of lamotrigine? Increase or decrease? They're going to increase. And then the opposite if they induce glucouronidation. So contraceptive pills, progesterone, combined estrogen-progesterone pills will induce glucouronidation, right? So we'll talk about what kind of a pill would you give, or sorry, what kind of contraceptive method would you give to a person, a woman who has epilepsy. Yeah. The other thing to remember is that antiepileptics, are they teratogenic? Yes. Yeah, they are. The vast majority of them are. So do you want your patient on them? No. So what do you want to do? You want to prevent pregnancy. But how do you prescribe birth control when they have so many drug-drug interactions, right? It can be tricky. So we'll talk about this point. So think about it a little bit when you get bored of hearing me talk. Okay, because I'll ask you guys. So systemic, again, rash, nausea, right? This is hopefully sounding familiar. There's a risk of developing Stevens-Johnson's or toxic epidermal necrolysis. It's a bit higher in kids. Again, dizziness and somnolence for neurological side effects. Okay, oxcarbazepine, I don't know how to pronounce many of these. This is very similar to CBZ. It's about half protein bound, 40%. This is a prodrug. What's a prodrug?
It needs to get
It
metabolized.
needs to get, exactly, yes. So it's metabolized to MHD, which is monohydroxy metabolite. And about 30% of that is renally excreted unchanged, and 70% of it undergoes glucuronidation. Again, so I'm hoping you're seeing a theme here. The other thing to note with oxcarbazepine is that you can't use it in combination with this other drug right here, eslicarbazepine, which is also metabolized. It's a prodrug that's metabolized to oxcarbazepine and then MHD. So you're not going to be giving, you're just going to be giving too much of one drug, right, if you're using it in combination. So that doesn't really make sense. Side effects, again, are very similar. Again, you see hyponatremia here, so we're going to talk about that. Again, rare is Stevens-Johnson's and toxic epidermal necrolysis. So you can see that in terms of the side effects of these drugs, they're very similar, right? So that should hopefully be helpful in remembering that antiepileptics as a group can cause these neurological symptoms, which tend to be dizziness, somnolence, lethargy, and then common systemic or physical outside of the nervous system would be GI, right, or rash. And then the really severe rash, Stevens-Johnson's, while it's rare, this is a group of drugs that you want to remember for that type of a rash. Okay, let's talk about hyponatremia a little bit. So basically the hyponatremia that comes from carbamazepine and oxcarbazepine is because you have increased responsiveness to ADH in the collecting tubules of the nephron. So this is considered to be one of the causes of SIADH. Is that term familiar to you guys? Mm-hmm. Yes? Okay, got it. So I won't get into this too much. But one thing to note is that this is more likely to happen with CBZ than it is with this other drug that I don't know how to say its name. And patients can be asymptomatic. So basically this has to be on your radar when you're prescribing any of these drugs to a patient. Clinicians will many times measure sodium levels in these patients. So right, you're getting a CMP or a BMP, right, a comprehensive metabolic panel or a basic metabolic panel, which is going to have sodium in it. So that's just going to be on your checklist of things to do. And then in terms of treatment, for mild to moderate hyponatremia, which is probably the vast majority of what you will see, is fluid restriction. Otherwise, you're going to stop the drug and start something else for them. Okay, phenytoin, it's another really old drug. Same mechanism of action. In terms of its pharmacokinetics, again, it's highly protein bound. So hopefully same theme over and over we're seeing here. Metabolized in the liver by both cytochrome P450 and non-cytochrome P450 enzymes. The big takeaway with the pharmacokinetics here is that it follows what's called non-linear kinetics. Does anybody know what that means? No? Nothing? Okay. Or saturable elimination. So let me see how I can explain this. Okay, so let me draw something up on the board. Yeah, should I draw it on that board? Or is that, no?
I just want to.
Okay, take it.
There you go.
You can
Got
turn
it?
it around.
Not blurry. Oh, like this. There, how do I turn this thing around?
That's okay.
Just, okay, you guys are good? Okay, so on this axis, we're gonna put steady state concentration of the drug. And then on this axis, we're gonna put dose. So with most drugs, as you increase the dose, what do you expect the steady state to do? It's gonna increase, right? And it's gonna be a linear increase. So phenytoin does this. Let me get another color. So at some point, it's not gonna be linear, it's gonna be non-linear, and it's gonna do this. So what does that tell you? With an increase, a little increase in dose, you're gonna get a big increase in the steady state concentration. So how's that gonna affect the clinical utility of this drug? Yeah, so what are you gonna have to do? Monitor it really closely as well. Yes. So small increases in a maintenance dose for this drug, okay, can cause huge increases in plasma levels. And you're putting a patient at risk of toxicity, basically. So this happens because this drug has what's called saturable elimination. So once it reaches a certain steady state in the body, the enzymes that metabolize it get saturated, basically, right? And to clear it after that dose is reached is going to take a lot of effort, right? And so you're going to get much higher levels of the steady state concentration for change in dose. Does that concept make sense? Okay. So I'm just trying to explain to you why we monitor the levels of these drugs really, really closely.
No, I'm sorry, I missed that.
Once this drug, phenytoin, reaches a certain concentration in the body, the enzymes that metabolize it, to get rid of it, to clear it, right, become saturable. So they're saturated with the drug, basically. And they won't be able to clear it at the same rate that they were clearing it at before it reached this concentration. So now, instead of giving, another 5 milligrams of the drug or something, I'm just throwing out numbers here, and then the steady state concentration going up along this line, that's going to go up a lot faster because you're not able to clear the drug as quickly or at that same rate that you were able to clear it at before when you were clear. So, and where this happens is different for every person. You can't guess where this is happening. And that's why we need to really monitor these patients closely because you can cause toxicity without even knowing it, right? By just thinking you're giving them what's a maintenance level dose, but for that patient, for some reason they don't have as much of that enzyme as somebody else, and so they're going to metabolize it a lot less or clear it at a lot slower rate than somebody else. So is this pretty clear? Yeah? Okay. So it can be given orally or IV. What else do I want to mention? So it has a narrow therapeutic window, which goes with this kind of picture right here that we've been talking about. It has a long half-life. So again, goes with this picture that we talked about, right? And then it's monitored or measured really closely in patients. So in terms of side effects, so phenytoin has some interesting side effects that you should be aware of. So it can cause gingival hypertrophy. What does that mean? Yeah, basically, yeah. And it's about 50% of kids that it can do this to, right? Hirsutism, which is increased body hair, yeah. Rash, again, Stevens-Johnson and TEN. Folic acid depletion and decreased bone density. So those are some things to remove. So patients who are on phenytoin sometimes will be supplemented with folic acid, calcium, and vitamin D for the folic acid depletion and the bone density. Again, the neurological symptoms, side effects are similar to the other drugs. And then phenytoin is one that is teratogenic. So it increases the risk of fetal malformations by about 2 to 3 times a person who's not on it. Okay. In terms of contraindications, it's not given to patients who have bradycardia or AV block or block at the sinoatrial node.
Question.
Yeah.
If someone's developing like a SJS on one of these drugs and you take the drug away, are you expected that that'll go away as well, or is it kind of like?
I have never seen a case of it. So for me to delve into the clinical kind of course, I don't know, like if you stop the drug, will it stop the progression of SGS? Probably depends on the drug, right? So with this drug, this has a long half-life. So my guess is you're not going to stop the progression that much, like phenytoin, for example, right? You will stop it though, for sure, yeah. And you will put a patient on another drug. But and some of these patients don't need to be admitted to the hospital. They're going to be, taken care of as an outpatient, maybe not in the critical care, but in the hospital. But my guess is with something like phenytoin, maybe where you have a long complex, I don't see the progression of it being stopped. Yeah, I think it will just develop along whatever course that it's going to develop on, and then hopefully if you've caught it early enough that stopping the drug may help the recovery of that patient. Yeah. I wish I could give you more information. I've never seen Stephen Johnson. Thankfully, obviously a horrible thing. Okay, so drugs that affect calcium current, we're just going to talk about one, ethosuximide. But just so you hopefully remember, there's 3 types of calcium channels in neurons. Ethosuximide tends to affect, the T-type calcium current. And this is the one that is usually given to kiddos who have Pharm seizures. So ethosuximide is used really in just Pharm seizures. So that is one indication that I would remember. Absence, ABSENCE, I think. Like absence, yeah.
But French.
Yeah, I don't know why it has that little thing to it. It is French.
Yeah.
Okay, so it's going to diminish calcium current into the neurons. And ethosuximide, thankfully, is one that doesn't have as crazy of a side effect profile. Again, you're going to have nausea, vomiting, you can get sleep disturbances, drowsiness, hyperactivity, and remember we're seeing what the effects are in children, and bone marrow suppression or depression, which is rare. Again, this is a drug that you're going to monitor serum levels with. You may also periodically monitor CBCs, and it doesn't have really any significant interactions with other drugs, so which is a nice thing. Okay, so let's talk about GABA. So what's GABA again? Inhibitory neurotransmitters. Yes. So what do you think these drugs are going to be doing?
Activity.
They're going to be somehow increasing GABA activity or effect, right? So GABA is a neurotransmitter, exerts postsynaptic inhibition. GABA receptor complex has binding sites for GABA benzodiazepines, which bind at a site that's different than GABA, than the neurotransmitter, and phenobarbital. When you are reducing GABAergic tone, are you lowering the seizure threshold or highering it? You're lowering it, exactly. So pro-convulsive, right? Something that will lower the seizure threshold and may increase the risk of a seizure. When you're increasing GABA tone, it's an anti-convulsant, right? Okay, so how is GABA made? Who remembers? What enzyme? Yes. And then what's the enzyme? It's on the board. GAD. Yes. So glutamic acid decarboxylase, right? That's gonna basically synthesize GABA. Infants, there are some infants who are born with a pyridoxine deficiency. What's pyridoxine? Vitamin? Yes. Yes. So they can't synthesize GABA and they are prone to seizures. Very rare. But just so you put the 2 and 2 together. In terms of its metabolism, what's the enzyme that's metabolizing GABA? GAD is synthesizing.
It is what is it?
GABA T. What's GAD or?
No. I thought you
Oh,
asked-
what's the? Yeah, GABA T, transaminase. So this is a brief review of GABA, and the reason why I mention it is because these drugs are going to increase GABA supply by doing what? How would you increase GABA supply?
By stopping GABA T.
By stopping GABA T, right? So that's going to increase GABA by lowering GABA metabolism. Or what's another mechanism?
Increasing the amount of GAD available to metabolize or glutamate.
Or you could, what is it called? Have a positive effect on GAD, I guess, of some sort, right? Yeah. And then, so what's another way to increase GABA in the synaptic cleft? Yeah, you would reduce its reuptake, right, by the neuron. It could also imitate GABA, so it will basically bind to the GABA receptor and cause the same effect. Or it could enhance GABA's effect on the cell. So,
Professor,
yeah.
can you go over the reducing GABA energetic tone again?
That's just so. Basically, that's just to think about how GABA is an inhibitory neurotransmitter, right? So if it's an inhibitory neurotransmitter, it's going to decrease the excitability and the action potentials that are going through a neuron. So if you are reducing GABAergic tone, then you are lowering seizure threshold. You're increasing the chances of a seizure, right? Yeah. Yeah. Okay. So let's talk about benzos. Have you guys talked about benzos in any of your other classes? No? Okay. So I will talk about a few of the benzos, and those are the ones that will be on the exam. I will not talk about the whole entire class because they're used for so many things. And they have a very specific role here in epilepsy, but we'll talk about it in just a second. So benzos are going to bind the GABA receptor, and they're going to facilitate attachment of GABA to its binding site on the receptor. So they're basically magnifying the inhibitory effect of GABA. What do we always hear when we prescribe a patient benzodiazepine? Okay, addiction. What else? A withdrawal if they were to stop it too quickly, right? And tolerance as well, right? So a patient can become tolerant, meaning that the drug that they're taking no longer has that same effect or degree of effect that it had when they first started it, or whenever they got to their maintenance dose. So this really limits its usefulness in epilepsy. So using benzos as a chronic form of therapy, and actually anything, whether it be anxiety, seizures, is usually frowned upon because of these effects with the benzos. So we tend to use benzos for status epilepticus, right? So the person who saw status epilepticus and saw a rectal drug, a drug inserted rectally, it was a benzo, probably, yeah. So they can help stop a seizure acutely. Yeah. Yeah. Yeah, that's the brand name. Okay. In terms of side effects, sedation, irritability, ataxia, depression, and then sudden discontinuation, can cause withdrawal. So we've talked about these things. So benzos have a ton of indications. I mentioned a few of them here. Diazepam is the one given rectally, and it's used as a rescue medication. So it's used to kind of abruptly stop that seizure from happening. You can't give it in glaucoma. And then in terms, we kind of talked about side effects already. This is for diazepam, sorry, specifically. In general, benzos are used for anxiety, muscle spasms, preoperative anxiety. My little kiddo had to have a surgery and was given a benzo and got really goofy on it and was saying crazy stuff before they did, general anesthesia and went to sleep. But, and then status epilepticus. So we talked about diazepam. What else I want to mention here? It's a controlled substance. So controlled substance means that it needs usually a special way of being prescribed. We're going through a lot of that right now in the medical world in terms of how we prescribe these medications. We talked about withdrawal. Lorazepam is another benzodiazepine that can be used for status epilepticus, and it's longer acting, has a longer half-life than diazepam, and sometimes it's preferred. And again, really very similar contraindications and side effects. Clobazam is also another one that's used, but it's used primarily outside of the US. So don't worry about that one too much, but just so you know. Okay. You guys sure you want me to continue the lecture? Yes? Okay. Okay. So phenobarbital is one of the oldest antiepileptics that we have. It's used for both generalized and focal seizures. It's used in anesthesia, and it can be used in status epilepticus as well. It's a similar mechanism of action, so it's going to bind the GABA receptor again, and it's going to improve the effect of GABA by extending how long you have chloride going through that channel, right? Okay, in terms of its metabolism, 75% is in the liver through the cytochrome P450 system, and 25% is excreted through the kidneys unchanged, right? So this is a drug that you're going to be careful of in patients who have both liver and kidney disease. It's also another drug that's a potent and broad spectrum enzyme inducer. So this is one of those drugs that you're going to worry about those drug-drug interactions. It's severely sedating, so that's why you can imagine it's used in the anesthetic world, right? It can cause cognitive impairment, ataxia, and Stevens-Johnson's as well, but again, it's rare. So in all of these drugs, Stevens-Johnson's reaction is a rare reaction, but it's so life-threatening that we have to be aware of it. Okay. Tiagabin. This is one of the newer agents. It's used as an adjunct. What's an adjunct treatment? In addition to, and something else. Yes, in focal seizures in 12-year-olds. So if you have a patient that you put on, I don't know, carbamazepine or something, right? And it's not enough. Their seizures got better, but not 100%. This is something you may consider to add on to another anti-epileptic. So this also enhances GABA action, and it does that by inhibiting GABA reuptake. So this one is inhibiting the reuptake of the neurotransmitter back in. So it's allowing GABA to hang out for a longer period of time in the synaptic space and to have a greater duration of action. It's metabolized by the liver, both cytochrome P450 and non-cytochrome P450. It does not induce or inhibit enzymes, so that makes it a great adjunct, right? So it's not going to affect the metabolism of other drugs. No serum checks are needed with this one. Its side effect profile is not as crazy, but it's very similar. So it can cause abdominal pain, it can cause dizziness, lethargy, yes?
Is it used as an adjunct because it's not as effective?
Yes. So I think in the studies that its efficacy wasn't as great as some of the older drugs. And so because it has such a great pharmacokinetic profile, right, pharmacodynamic profile, it's used as an adjunct, I think, for those two. Yeah. Okay, so side effects are pretty similar, but not as intense, right? So you get abdominal pain, you don't get the nausea, maybe some nausea, but you're not going to get the vomiting. You do get dizziness and lack of energy, but you're not getting like the rashes, the Stevens-Johnson. So its side effect profile is a lot more limited in that aspect. One thing maybe to be aware of with this drug is this drug has been given off-label in psychiatric conditions. And some people have noticed, some researchers noticed that patients who took this medication for psychiatric or for pain reasons may have had their seizure threshold lowered. And it was a proconvulsant, and they can't explain why. I put some possible explanations, but they're just theories. So just the main takeaway is that it's not, as of now, considered a proconvulsant in patients who are taking it for seizure, as a seizure medication, but in those who are taking it for psychiatric or pain reasons, it may lower their seizure threshold. So just be aware of this particular controversy with this drug, and maybe this is something that will be resolved, in the next, 5-10 years. Vigabatrin. If anybody knows how to pronounce any of these, please help me out.
You got it.
So this irreversibly inhibits GABA T. So what does GABA T do? Yeah, metabolizes GABA, exactly. So it's raising the concentration of GABA. Okay. Again, this is an adjunct for patients. It can be used as a monotherapy, but it's not as effective. So same kind of profile as the last drug. It's renally excreted, so it does not undergo metabolism, but it does induce cytochrome P450. Okay. So even though it's not metabolized by the liver, it's still inducing those enzymes. So drug-drug interactions again are going to come into play. This drug has a FDA box warning for vision, permanent vision loss. So this is something that you're going to want any patient who's going to be on this drug, you're going to want to tell them about this, so that if they start to suspect anything, they're going to call you ASAP.
What's infantile spasms?
Infantile spasm. So it's a form of seizures in infants, basically. Yeah. So basically, it can up to 50% of patients on this drug can have irreversible vision loss. So that's a big deal, right? So you're going to tell patients about this potential side effect when you first prescribe it, and you're going to basically warn them that this could happen, so that they're on the lookout for it if they agree to take it. Okay, so because of this box warning, this drug is usually reserved for what are called refractory cases. So cases that are not responding to other medications, right? So it's a last resort type of drug. It can also produce MRI abnormalities, so radiologists can see things on the MRI that may not really be there when a patient is on this drug. So again, if you have a patient who's on this drug and they are getting a brain scan for some reason, you want your radiologist to know that they're on this drug. That would be something that you would maybe write in your orders, you know, when you put down your little reason about why you're ordering the scan and what you want them to know about the patient's history. This would be on there. In terms of its side effects, pretty similar. The one thing that I remember with this that's a little different is that you can have a severe hypersensitivity reaction and angioedema. Does anybody know what angioedema is? Yes. Well, yeah. And what do we worry about with angioedema?
Blockage of your
Yes, exactly. So it can be an emergency. Yeah. What do we have to worry about for angioedema?
I didn't hear.
Oh, angioedema, it's swelling of the face, and basically the airways can be blocked from the amount of swelling and edema that's happening. And so sometimes these patients need to be intubated. Yeah, until the swelling is, you can control it with steroids or treat it. Okay. Drugs that affect the glutamate receptor. So what's glutamate?
It's excitatory.
Excitatory, right? So now we're talking the opposite, the flip side of the coin, right? So GABA is inhibitory, glutamate is excitatory. What are the two receptors that glutamate has?
AMPA.
Yes, yeah, NMDA and AMPA. Inotropic is going to be your NMDA and your AMPA receptors. And inotropic means that it's what kind of a channel?
The ion channel.
Exactly, yes. So it's forming an ion channel, right? And it's activated by glutamate. And then what's metabotropic? G protein signaling, yeah, that cascade, that effect that happens. Okay. So we have one drug that affects AMPA. It's going to do what to AMPA? Remember, it's glutamate, so we want to antagonize the glutamate receptor to lower the excitatory effect, right, that's happening in the neuron. So that's Pharm panel. Again, I have no idea how to pronounce many of these drugs. And then NMDA antagonists, you're going to have two, felbamate and topiramate. Topiramate we use quite often actually for migraines. So that one I am familiar with. But that's how these drugs work. So they're basically antagonizing the receptors that glutamate works on to decrease the excitation that's going on, right, in the cortex. Okay.
You said felbamate is used often for headaches?
Topiramate. Yeah, topiramate is used often outside of the seizure world. Yeah. So we'll talk a little bit about that. Okay. So in terms of Pharm, this is another drug that can be used in children. So it can be used for focal seizures in young children as young as 4, and it can be used as an adjunct in older children or adults in 12+-year-olds. In terms of its metabolism, it's hepatically metabolized, cytochrome P450 and glucuronidation. It has a really long half-life, so this is going to be around for a while after you stop it. And it can take up to 2 weeks to reach its steady state. In terms of, obviously, liver disease, like any of these drugs that are metabolized through the liver, you're going to be cautious about how you use it in a patient who has liver disease, right? This is another one that can reduce the efficacy of, this time, levonorgestrel, containing hormonal contraceptions. So what is levonorgestrel? A progesterone, yeah. Yes, so it's found in birth control, exactly, birth control method. Okay, in terms of its side effects, it can cause dizziness, somnolence, headache, fatigue, irritability, gait disturbance. So it can cause a lot of kind of nervous system side effects. It can also alter mood, it can cause aggression and homicidal ideation, self-harm. So this is a drug that you're going to monitor a patient on very closely. And in a kid, what do you think you would see? Homicidal ideation? Aggression. You would see aggression. Yeah, you'd see aggression, you'd see altered mood. And this side effect profile is a reason why this drug is generally not used or is stopped. Okay. So drugs with multiple mechanisms of action. I know I had put felbamate in the glutamate group of drugs, but so it also augments GABA, we think, in rats, maybe in humans too. So that's why it's under the group of drugs that have multiple mechanisms of action. But really what I remember about felbamate in terms of its mechanism of action is that its effect is on the NMDA receptor. Okay, so its indication is very specific. It's for a specific syndrome. Lennox-Gastaut, I have no idea how to pronounce it. This is basically a syndrome, a childhood seizure disorder that you see also with cognitive impairment, and it can be resistant to standard anti-epileptic medications. So felbamate is used for it. It's not a first-line drug because its side effect profile is pretty scary. It can cause a fatal aplastic anemia. So, and the aplastic anemia can occur months after the drug has started, and it can be a risk even after stopping the drug. So this side effect basically has rendered it not useful in the epilepsy world, but for some reason it works in this particular syndrome. Its metabolism is half renal and half hepatic. And one of the drug-drug interactions is that it can increase the conversion of carbamazepine to its active metabolite. It's not an understood interaction, but it's something to be aware of. Okay. So pyramate. Okay. Almost done. Yes. So we talked about mechanism of action. It has other mechanisms of action as well. So this one is going to antagonize NMDA, right? Glutamate. But it's also going to block the voltage-dependent sodium channels. It can also enhance GABA activity by binding to the GABA receptor. So topiramate works in a number of ways. And it can inhibit carbonic anhydrase in the CNS weakly. And I think this mechanism of action is not really understood. It's not understood why it may help with seizure, lowering the potential for seizures, but it's something that we've noticed about this drug. Topiramate is used as an adjunct. It can be used as a monotherapy in new onset epilepsy, but it's mostly adjunct. And I've seen it used tremendously in migraine prevention. It also can affect the effectiveness of hormonal methods. So it has a lot of side effects. Most of them are not scary, they're just kind of weird. So weight loss, which, who knows, maybe it's because of reduced caloric intake. Patients aren't hungry on this drug for some reason, but the weight loss seems to stabilize over chronic use. It can have also impaired cognition that can show up as aggression or behavior worsening in children, mood problems or depression. It can cause paresthesias. What are paresthesias? Tingling and numbness, yes. Headache, fatigue, dizziness. And these, basically this group of symptoms or side effects will decrease with continued use of the drug. So sometimes you have to kind of coach a patient through that initial phase of using the drug, and then that will go away. The rest of the side effects won't decrease with continued use, but they can have decreased sweating, so that can make them intolerant to heat. There's been reports of effects on the eye, so glaucoma and myopia. And then metabolic acidosis, and that comes from the effect on carbonic anhydrase. And it's a very common effect to see this metabolic acidosis in patients with impairment. Usually it's mild, it's not something you're going to worry about. So you may need to stop the drug if it is a big deal in a patient. So if they're developing stones, for example, right? Renal stones, kidney stones. And you're going to monitor these patients with a bicarb local, basically. This is also teratogenic. So in utero, babies can develop cleft lip or palate if mom is on this drug, or low birth weight.
So the first 3 bullet points will decrease with continued use?
Yes, except for weight loss and paresthesia. Everything else will decrease with continued use. The weight loss will, we think, stabilize after being on this drug for a number of years. Basically.
Wait, I'm sorry. I got confused again. Which ones will decrease with continued use?
So all the top 3 points, except for weight loss and paresthesia.
Okay.
So headache, fatigue, dizziness, and others. Yeah.
Thank you.
Yeah. Okay. We're almost done. So valproate or valproic acid, another really important drug to remember. It can be used for, again, migraines. It can be used in mania and for seizures. It's going to work in a number of ways. So it's going to affect the voltage-dependent sodium channels. It's going to increase the concentration of GABA. And it's going to act on the calcium current as well. So it's like hitting all of them, basically. It's highly protein bound, especially to albumin. So if a patient has hypoalbuminemia, it can cause toxicity if they're taking this drug at a normal dose. So again, something to be aware of. So how is that happening? There's not enough albumin around in the body. So the drug is not bound to albumin. It's going to have an effect, right? It's going to be active, or it's going to have an effect on the organ systems. And so you're going to have a lot more of it hanging around than you would expect in somebody who is not hypoalbuminemic, right? Has sufficient levels of albumin. So does that make sense? A normal dose of this drug can cause toxicity. Okay. It's metabolized in the liver, and it also inhibits cytochrome P450 and glucuronidation. So you're going to monitor this drug very carefully. The extended release form of this drug is going to give you more stable dosing and levels in the blood. Oral contraceptive pills, OCPs, that's what that stands for, can increase the clearance of this drug. So a patient who's on birth control and they're on valproate, what's going to happen to them during their placebo week? What's that? What's going to happen to valproate during the placebo week?
It's going to be more
It's going to increase, yeah. So placebo week of OCPs are what? Non-sugar pills, non-hormonal pills, right? A very low dose of hormone, depending on the brand or what you're getting.
It would increase the clearance?
It would. So during the placebo week of oral contraceptive pill, so let's backtrack. So oral contraceptive pills will increase the clearance of valproic acid, right? So if a patient is on the pill and on valproic acid, and she's on a 21/7 formulation, everybody know what that means?
Mhm.
Yeah, so 21 days of active pills,
7 days
hormonal
of
pills,
placebo.
7 days of the placebo, non-active, low hormonal, or no hormone pills, right? So what's gonna happen during that placebo week? Valproic acid is gonna go up. The levels of valproic acid in the body will increase.
Sorry.
Yeah, let's maybe if we draw it out. So, so birth control pills come in lots of different what are called formulations, right? So most of them are 21/7 or what was it? 24, thank you, 24/4, right? So basically the first number, the 21 or the 24, and some are 84/7, right? What does that mean? What's that?
They have 84 days back.
Yes, exactly. So that means they have almost like 3 months, right, of no bleeding. Sorry. So that first number, 21 or 24 or 84, or 84, right? Not 87. Now I'm thinking so. It's 84. Yeah. So those pills that you take from day 1 to 21, or day 1 to day 24, or day 1 to day 84 are hormonal pills. They contain hormones, usually a combination of some form of estrogen and some form of progesterone, right? And then the 7 days that or the 4 days in the 24/4 formulation, right? Those are going to be what are called, some people call them sugar pills, which is a really weird term for them, but they're going to be pills that don't contain hormone or a really low dose of the hormone, basically, right? Yeah?
No, I get that.
Okay.
I'm just trying to understand that.
Yes. So if birth control pills, hormonal birth control pills, cause valproic acid to be cleared much faster, right? What is that? If you have a patient who's taking valproic acid or valproate and birth control pills, what's going to happen to their valproic acid levels when they're on that placebo week? When they're
Oh, that would be high.
Exactly.
Oh, I think that what I was hearing was that the clearance would be high. I'm like, how's the clearance?
No, yeah, the
should be
level
low.
of valproic acid will be high because the clearance rate has, yeah.
I was
So-
hearing clearance.
Yeah, okay. And then I listed a bunch of drug interactions. Valproate is one of those drugs that has a lot of drug interactions. So valproic levels can be decreased by other enzyme-inducing drugs. We just talked about that with birth control pills. And it can inhibit the metabolism of other drugs, both antiepileptics and other drugs. So, okay. So again, this is a drug where with any antiepileptic, you're really going to want to check the drug-drug interactions for these patients. And you will want to check it. Do not rely on anyone to do your work, whether it be a pharmacist or somebody else. You always want to be the one to check. They should be double checking your work, working together. But okay, in terms of its side effects, there's quite a few. So common ones that we've talked about: nausea, vomiting. Here's hair loss, right? We saw hirsutism, increased hair growth, but this one can cause hair loss, tremor, weight gain, obesity, insulin resistance, metabolic syndrome. Those, hopefully you can group them together like we did with which other drugs? Which other group of drugs did we see? Metabolic syndrome. And what's that? Yeah, insulin can cause it, but what was the other big group that we really honed in on its side effects in terms of metabolic syndrome? Think about what were they in?
Antipsychotic.
Antipsychotics. Which generation?
Atypical.
Atypical. Good. Yay. Okay. Like many of the antiepileptics, it can cause effects on platelets, coagulation disturbances. It can cause easy bruising because of that. Subclinical hypothyroid, whether that is anything to be concerned about, who knows? I would probably be just concerned about it with somebody who has underlying thyroid disease. It can be associated with PCOS. Did you guys talk about PCOS? Polycystic ovarian syndrome, which we use birth control pills for, right? Patients who are on PCOS. So you can see how this is going to get complicated. Fanconi syndrome, which is another, did you guys talk about Fanconi syndrome and
Yes.
hemo?
Yes.
Okay. What's Fanconi?
It's one of the congenital causes of aplastic anemia in which they have skeletal deformity.
Yes. Okay, it can also be teratogenic. It can cause ALT elevation, which can resolve. It can also cause really serious liver toxicity. So valproic acid, remember that it can cause really serious liver toxicity that can result in liver failure, coma, and death. So something you monitor patients for. It can cause pancreatitis. Why again is not understood for these side effects, but these are reports of cases in patients who have been on valproic acid. So again, and then other case reports have talked about Parkinsonism and cognitive decline. So kind of a scary side effect profile. Yes.
For PCOS, can you explain a little bit more why you be careful with birth control?
Why you would use birth control in PCOS?
Or like
What is PCOS stands for polycystic ovarian syndrome. You will talk about it a lot next semester, so I won't get into it too much. But a lot of these patients have irregular menses, and then sometimes on ultrasound, not always, you can see a lot of cysts in their ovaries, and why that is not known. You'll get into a lot of this with Dr. Nelson. But we use birth control pills sometimes to help regulate their menses. And so if you have a patient who has PCOS, then they're on valproic acid, then it's like, which came first? I don't, there's an association. So whether it actually causes PCOS or not, it's not known. But if you have somebody who has PCOS and they have epilepsy, you're probably not going to use this drug. Yeah, okay. And then I think this is it. This and one more. Okay, gabapentin. We use gabapentin a lot. Has anybody seen gabapentin being used? Yeah. For use in diabetes for yes, neuropathic pain. Anything else that you've seen it being used for? That is the biggest one, yeah, in primary care. But what's that? Yeah, you'll see it being used for a lot of what we think is pain that's neurologic and in cause. But you can see it being used in the gyne world for vasomotor symptoms. Remember SSRIs that are used sometimes for vasomotor symptoms, so hot flashes, perimenopausal symptoms. Sometimes we'll use it there too. So I put a bunch of indications for gabapentin. It's a very heavily used drug in medicine. So this is going to affect voltage-dependent calcium channels, not the T-type, but the voltage-dependent calcium channels. But same kind of thing, it's going to inhibit that inward calcium flow that causes depolarization and natrium potential. I listed a bunch of indications in terms of its pharmacokinetics. So its interesting fact is that it's absorbed via amino acid transport system in the intestines. It does not bind to plasma proteins, and it's not metabolized. It's primarily excreted through the urine. So it kind of goes the opposite of a lot of the drugs we've talked about. It doesn't also induce or inhibit enzymes either. So it just has an interesting pharmacokinetic profile. In terms of side effects, sedation, dizziness, ataxia, weight gain, GI irritation. It can be misused, but it's a really commonly used drug. You usually, in terms of the side effect profile, to kind of mitigate that, we start it very low and increase slowly. And a lot of times this drug, it can be given throughout the day, but a lot of times it's given at bedtime because of the sedating side effect. Okay. Yes. What's that?
RS.
Risk factors. Risk factors in a patient who has a history of substance abuse, so you may be more wary of using this drug. And then the side effects are more common in patients who are older. Those who have renal disease, you're going to be more cautious about the dosing. And those who have comorbid conditions, so other chronic medical conditions. And then last slide, yay! Okay. Okay, we're good on time, actually, really good stuff. So it's going to, in terms of its mechanism of action for pregabalin, It's going to, again, bind to those voltage-dependent calcium channels. It may also modulate the release of glutamate, norepinephrine, and substance P. In terms of its net result, it's going to inhibit neuronal activity. So that's what we want to do, obviously, in patient with seizures. It's used as an adjunct, and it's also used in pain, similar to gabapentin. And then very similar to gabapentin in terms of its pharmacokinetic profile. So doesn't bind plasma proteins. It's not metabolized in the liver. It's excreted renally. It doesn't induce or inhibit enzymes. So it's very similar. And then in terms of its side effects as well are also very similar. So dizziness, somnolence, ataxia, weight gain. It can cause edema. It can cause blurry vision. Asthenia, which is like decreased perception, I guess. Tremor, abnormal thinking. It can also cause euphoria. So it's a controlled substance as well. Okay? Okay, so that's it. How are you guys doing? Good? Okay, any questions? Yes.
Do you hear about anybody like saying like using CBD and antiepileptics?
Oh, CBD? Yeah, I don't know a lot about it, but it's an interesting area of research. Marijuana. It seems to be used a lot more in the peds world, I think, than in the adult world. There's a physician out of CHLA, actually, who has a clinic, a CBD clinic for pediatric epilepsy patients. I don't know a lot about it. I think hopefully now that it's legalized, we'll have a lot more funding for research, and that will help clarify if there's a role for it. I mean, it seems to have a role in a lot of neurological diseases like Parkinson's, right? I don't know if anybody's ever seen that video of the guy who had Parkinson's and he took the marijuana oil, right? And then like his tremor went away and the masked faces, right? Where so patients who have Parkinson's get a symptom called masked faces, which it's like as if there's a mask over their face. They can't portray emotion. They can't move the muscles of the face as much, so you don't really know when they're happy because you can't see them smiling as much as they used to before, right? So it seems as if like they have this mask on. But this guy took this marijuana and then it was just like a different guy. It was really weird. His tremor stopped. He was like acting normally. His voice didn't shake. It was really crazy. I don't know a lot about it. I had looked into it because my uncle had Parkinson's, but he didn't want to try it, so I didn't get much further than that.
What if like you ingest it instead of having to smoke it? Would it give you like the same?
Yeah, there's a lot of research about whether the oil is better or inhaling. The thought was that inhaling will be more acute, but maybe the effect won't last as long.
Yeah.
Versus ingesting it in an oil form where it gets absorbed under the tongue or the cheeks or something.
Yeah.
I had a cousin who was diagnosed with cancer who took it or tried it for chemotherapy but didn't see a huge effect. But her story was interesting. She had medulloblastoma, which is rare in adults, and then it made her dizziness worse. So she stopped it. She didn't take the marijuana. She didn't try it. So I don't know. They usually will tell you to start very low and just increase up to whatever you feel is a therapeutic effect for that patient, and the patient kind of does it for themselves. If you don't tell the patient like take this much. So yeah, I just feel like it's an area of research. Yeah, I don't know a lot about it, but I know it is used for these things. Yeah, and it may have a role in seizure treatment, but I don't think we're there yet where it's being used widely. Yeah. Does anybody have experience in neurology? Wants to share if they saw any patients doing it, trying it out? Yeah. Okay, do you guys want to go through Dr. Nelson's lecture? Yes?
Yeah.
I can pull up the slides. How do you guys want to, do you have, first of all, specific questions that you want to ask? Yes.
Just the difference between progesterone and progestin. I just couldn't get like
So you're going to test my knowledge of all the generations of progesterone, which I don't remember. Does anybody know the answer to that question, first of all? What's the answer? Yes? No? Nobody knows?
thought.
I thought
It's
it was
still-
a
I
synthetic
think-
drug.
At first
Yeah.
I thought it was just like a synthetic version, but then she just kind of, it seemed like she was using it interchangeably, so.
So
if
I
this
don't,
progestin has,
I,
like-
yes, that would have been my answer. I need to look it up. So if
Okay.
anybody wants to like Google progestin versus progesterone right now, maybe try that. But my guess is that it's just used interchangeably to mean progesterone. And maybe progestin is the synthetic form of
Because
it.
another site that I looked at said that it was a combination of progesterone and estrogen.
No,
So I was like,
I've
that's
never
not-
seen progestin used to mean combined.
Okay, so just like a synthetic analog of
Probably,
progesterone,
yes.
similar
Yeah.
side effects.
Yes, but is it a specific generation? That would be my next question, which I don't think it is. I think it just refers to progesterone
Okay.
and probably like synthesized progesterone. But somebody look it up and see what else you guys can
So
find.
you think it's just a progesterone derivative that acts on the receptor?
That's what they
Okay.
said.
Okay.
Thank you.
It just says bioidentical progesterone versus synthetic progesterone. So progesterone is synthetic.
So progestin is synthetic. Okay.
She didn't finish the entire lecture, but I assume it's still responsible for.
No, I don't think so. Yeah. I would really focus on, you will not be tested on abortion and PCOS. I don't remember what the rest of the slides were on. Does anybody remember?
On like infertility and stuff.
Infertility, no. There won't be questions on infertility or abortion or PCOS or any of that stuff. So,
No questions as in like.
No
reference to the
exam
topic
questions.
Or, because they were like medication sessions, so
yeah, no. The questions on the exam will really be about the hormonal therapies that you guys already discussed, which is mostly for contraception. I don't think you guys talked about PCOS or abortion or infertility or any of that yet.
She stopped at like vaginal range on the.
Yeah. Did she talk to you guys about using some of these hormonal methods for menopause?
Yeah.
Yes. Okay, so I would be aware of that, okay? So in menopause, we tend to use the exact same hormones, but at different doses, right? And we use it to treat, what kind of symptoms did you guys discuss in class? Hot flashes, which can develop, which can come, vaginal dryness, which is a big one. A lot of women get vaginal dryness, right? And that can cause what? Vaginal dryness can cause
Bleeding and like
atrophy in the vagina, bleeding,
infection.
dyspareunia, which is pain on intercourse, infection, increased risk of UTIs. Yes, so that's a big one, right? And all of these are happening because of what hormone is decreasing? Estrogen. But is it completely gone from the body? No. No, why is that?
Because some androgens are converted.
Yeah, androgens are converted to estrogen in adipose tissue. Exactly, yes.
But it's less
We all have to
potent,
answer that. What's
Is it
that?
less potent?
Yes, it is less potent. Yeah, so the ovarian estrogen is gonna be your most potent. Yeah, that's what's gonna affect your hormonal cycles in female patients. That's gonna affect them going through menopause and, when they go through menopause. So when the ovarian follicular reserve starts to decline, right, all that kind of stuff. Then you get less estrogen production and then you go through perimenopause. Yeah, you can stop producing estrogen production. And you can induce menopause in a young patient. How can you do that? Patient has an ectopic pregnancy in the tube. So remember uterus, and then you have your fallopian tubes kind of going out the back, and the fimbria or the little fingers off the tubes are right up against the ovaries. And if you have an ectopic pregnancy, or if you have a cancer in the fallopian tubes, or if you have something, you may be removing that patient's ovaries, and you can cause menopause, essentially, in a young patient. Hysterectomy is just removal of the uterus. Oophorectomy is the removal of
everything.
So many patients will get a hysterectomy, but the ovaries are left behind so that they don't go into surgical menopause. Yeah. If you do have a patient who goes into surgical menopause or has primary ovarian failure, so their ovaries fail at a young age. I had one patient that happened to them. You can start hormonal contraception because of risk of osteoporosis and a whole host of other things, right? That estrogen, lack of estrogen can cause in a patient. Yeah. Do you guys want to talk about specific slides? Yeah.
I have a question. I just wanted clarification. For estrogen, it says it causes thinning of the cervical mucus.
Yes.
And increases its volume. What's its volume? Like the volume of the.
It thins out the mucus and increases the volume of that mucus. So it makes it more watery and more abundant.
But then progesterone thickens this.
Yes, progesterone thickens.
Can you explain
how it thickens it?
Well, what does it mean by thickening?
Of the cervical mucus?
That like the mucus gets thicker so that it won't allow the sperm to go through. Because you already have an egg that's fertilized, so you don't want more sperm.
Okay.
So it thickens and it keeps it thickened throughout the pregnancy.
And then for estrogen,
Thins it out, makes it more watery. Yeah, you can think of it as viscosity.
Right.
Like if you think of viscosity of a liquid, right? Something that's more viscous, it's going to be more like slime, right? Like slime is going to fall out of the cup like that, right? But water is going to flow out, which is less viscous.
Thank you.
Yes. So sperm is not going to be able to go through slime, but they'll be able to swim through water. Yeah.
What's the mechanism of like estrogen as
You're asking me a hard question. What is the role of estrogen in birth control? Can anybody answer that question? Is it in your slides? Look. So you're asking me why are they putting estrogen in birth control pills, essentially? So in general, how I think of birth control is it's essentially suppressing our own HPO axis, hypothalamic pituitary ovarian axis, right? And when you suppress that, by giving synthetic hormones, then you're going to suppress menses. And the whole process of producing follicles that will produce an egg that will provide the potential for ovulation and fertilization of that egg, basically. So it's kind of the overarching idea behind birth control. Yeah.
Summarize, so it's like negative estrogen have a feedback.
So if you're giving estrogen and progesterone synthetically, your body will stop producing it, right? And so once your body stops producing it, and you're overriding the natural production, you're essentially also stopping ovulation. And so that's how you're preventing the possibility of a pregnancy. But that's why sometimes when women, so maybe we can talk about the, we can talk about how antiepileptics and birth control pills overlap. So if you have a patient who's on a strong enzyme inducer, so it's going to inhibit the effect of an oral birth control pill, right? Or decrease the efficacy of an oral birth control pill, what would you recommend to that patient for contraception? It's a young patient. Vaginal ring, okay. That's a great thought. So
injection? Can you do injection?
So for some reason, remember injections. Let me look at my cheat sheet. I don't want to say the wrong thing.
I'll ask them the question.
Yeah, okay, so I've heard vaginal ring, injections, patch, okay.
Pretty much anything that's not oral.
Yes. So what would you think would be the safest method? No, for some reason implant, it affects the implant. Yeah. No. What would be the safest method of birth control? What would be a more effective method of birth control? So what effective methods of birth control that we have.
Condoms.
No. Okay, yeah, absolutely. That's what I was But yes, that is considered a method, especially by Dr. Nelson. She will lecture you on it if you think it's not a method.
You mean the IUD?
But yes, IUDs are highly effective methods of birth control. Why? Okay, so put aside antiepileptics for a second.
Because you don't need to do anything.
Because you don't need to do anything. Exactly. Yeah. What else do you not to really need to do anything for?
The next one on.
Nexplanon, exactly. What's that? Yes, so antiepileptics interact with implants. Yeah, with the progesterone in the implant. Yeah. But IUDs are probably going to be your safest bet. Both the hormonal and the non-hormonal form of IUD will be the safest bet in somebody who is on an antiepileptic medication. If you want to be extra cautious, I guess you could give them the non-hormonal, but Dr. Nelson probably lectured me on like how that's not a correct answer. So both. And if you remember, the hormonal IUD is acting really locally, right? Not systemically. It's acting on the uterus to prevent, what did we talk about for cervical mucus? Thickening of the mucus, sperm motility, right? So it's acting locally, and so an antiepileptic is not going to mess with that mechanism of action for an IUD, basically. But in general, so you can give an IUD, either type. Implant, we said no. Depo, for some reason, yes, you can give. I would double check, though, the antiepileptic with the progesterone that's in the depo, the medroxyprogesterone. But I think most research has shown that it doesn't really affect the efficacy of depo. But it would be something that I would really want to double check if I'm in clinic and prescribing a contraception for a patient who is on an antiepileptic medication. It won't affect the IUD, yeah. What else could you do to the birth control pill? Increase the dose. Yeah, you can increase the dose. Yeah. So you can give 50 of the estrogen, which is not in a lot of pills. We have a few pills that have 50. But we don't really use those anymore because those are really high doses of estrogen, and we're always worried about what with estrogen. DVTs, yes, clots, blood clots, yeah. What's more, what's that?
Hyperplasia.
In terms of what, sorry? Unopposed estrogen. Yeah, let's talk about unopposed estrogen. So, yeah, what are you worried about with unopposed estrogen? What does that mean, and what are you worried about with hyperplasia of the endometrium, which is the lining of the uterus? Hyperplasia can become cancerous. Exactly, yeah. So if you have a patient who's menopausal and has had a hysterectomy, can you give them unopposed estrogen? Yes. Yeah, you can. But if they have a uterus, then no. You would have to combine the estrogen with progesterone. Exactly, yeah. Yeah, good. What other questions do you guys have?
Can you look at the generations again?
Test me. Let's pull up the slides because I'm not going to remember.
Because I know she put it under progesterone only, but then she mentioned that some of them had estrogen in it, so I was kind of like confused.
Do you have the slides? Does anybody have slides in front of them? I can take a quick look at it.
The slides are different though.
The slides are different?
Yeah, when I printed this was like different from Pharm.
She updated it.
Yeah.
Go on to 4.
Let me pull up because she sent me the latest slide.
This one.
Yeah, I was going to do it.
This one.
Pill progestin by generation. Okay. Natural progestin. Are you talking about drospirenone, which has an increased risk for blood clotting?
Yeah.
Did she say that has estrogen in it? I wouldn't think.
Yeah, she did.
Okay, so drospirenone, which is I think fourth generation.
No, I think it was norethindrone.
Norethindrone?
I can't pronounce anything.
freaking librarian.
So drospirenone has an increased risk of blood clotting, but I've never heard that it has estrogen in it. It's a type of progesterone. No? Okay.
I don't remember. It's like at the middle of the spectrum. Go around the middle.
Let me pull up the slides on the computer screen.
Oh, here it is.
Yeah, so that one.
And then I asked. It's 74.
Is that the new record?
I like it when you said that. 10 out of 10. Wait, this guy's also not
I
Saves you time. What slide was it? 71?
I don't have that on this check stuff. I don't have that.
Yeah, me neither.
Maybe I wrote it wrong.
I think three is the one that.
Word on the street? So word on the street?
Bree has estrogen?
I forgot what slide it was.
That's what she's saying.
Testing it out.
No, I just said, I don't remember, it was like on there.
I think she wrote that.
How's it?
I don't have anything about it saying
Okay, so it's that one. I thought she was
Drospirenone.
It doesn't increase. Yeah, it just lets it out. It's the same as
It's not. It wouldn't have that.
It's the same volume.
I don't have anything. You have anything?
Physically, it's the same volume. You know, that's what I think it's the same thing. If you were to throw something and your mouth, it's the same
I tried.
See?
I think it came notes.
Yeah.
This slide?
You don't have a meeting notes. Like, I wish I could do
So what was the
So it should say volume, because volume is top subject, right? It will be the same.
If it's intuitive.
Yeah, or
It's like comparing an ice
right. But then
anybody else here?
You say that because I think it's
it's not the same volume, but it's the same amount, she said. I guess, okay.
In reference to generation 3.
I think that's what it was. She mentioned on the side another drug, orthotricycline, and
Treat mild access.
which has that, and I think that's just like a side note that she
And then
made.
somebody wrote something about it.
Yeah, but then that's what confused, it's like,
Yeah, so
right?
orthotricycline low has estrogen in it, and that's listed underneath the generation.
Okay, yes, so orthotricycline low has that generation 3 progesterone and estrogen.
Oh,
It's a combined oral contraceptive. And it's probably the progesterone that's helping the acne, not the estrogen. So orthotricycline or orthotricycline low, do you know what the difference is between orthotricycline and orthotricycline low? Low, exactly, it's in the dose. It just means that the estrogen is a lower dose in orthotricycline low. So I think Dr. Nelson mentioned that orthotricycline, which has that generation, generation 3 progestin plus estrogen. It's a combined oral contraceptive. And it can also be used to help treat acne. Cystic acne, which is a really hard form of acne to treat. And it's the progesterone that is helping to treat the acne, not the estrogen.
Okay, so.
Does that make sense?
Yes.
Yes,
That makes sense.
unless
Thank you.
she pointed something out, but.
No, that's what she
to
had
my-
mentioned.
Okay.
I still need to do it.
Yeah.
Sorry, I needed to add.
No, I know, it's fine.
Orthotricycline and orthotricycline will have both progesterone and estrogen. The vast majority of pills that you will need are going to be combined oral contraceptive pills. Very few of them are just progestin only pills or progesterone only pills. Orthotricycline is definitely a combined. It's a very commonly used drug. So yeah, and it has generation 3 progestin. I don't remember which one. Norgestimate. Okay, has norgestimate. I wouldn't worry too much about remembering that orthotricycline low has norgestimate plus estrogen. It's more, she wants you to know that generation 3, okay, is going to help you with cystic acne. Yeah. Because it's plus estrogen. Yeah. It was 3, not 4 that she's talking about acne?
Yeah.
3? Did she mention acne with 4?
She mentioned acne with 2.
2.
2 and 3. She mentioned acne.
With 2 and 3?
3 is the main cause of acne, right?
Okay.
I'm having. Oh, It has a high risk of clotting.
Yeah, I have that too.
So just use on with what's up with this.
Lord has the higher risk of blood clots, which makes sense.
Or
Which one?
higher risk of blood clots. I was 1 for.
One, okay.
Stan just over here like, ah, fuck this.
Oh, I have that too. Damn. Okay, you see that's what I'm on the side. It's not
She's so curious.
Yeah, you can give them
Are you ticklish?
Nah, bro.
You have a pain there? What happened there?
I don't know. I just didn't want it.
Just didn't want it.
Yeah, no. Hey, where's my photo? Okay.
I do that a lot. I need to stop myself.
What do you mean?
Squeeze people's thighs like that. It's a
No,
family thing.
it's not the thigh, that's the knee, bro.
It's like at the point.
Bruh.